Hello, everyone. Welcome. Welcome to, some of us are in person, and so we have masks on, and others are on Zoom, and we're just happy to be able to have the seminar in spite of all the craziness going on at Melbourne right now. And we were hoping to have Claire in person, but unfortunately that didn't work out, but we're really happy that she's still able to join us via Zoom. So welcome to Clair Sullivan. She's the head of Queensland Digital Health Research Network at the University of Queensland. And she has this very desirable dual role of straddling the university and the health service. And so she's the clinical informatics director of research at Metro North Health and also a practicing physician. And we have invited Claire because she's an influencer in Australia and globally in digital health and informatics. And she really combines the strategic and the practical together. And that's what we need here, I think. And so we wanted to learn from her and really looking forward to what you have to share with us, Claire.
Oh, thank you, Wendy. I am so sad that I am not down in Melbourne with everybody, but we'll try to make this as fun as possible. We'll have plenty of time for questions at the end. And I really hope that the outbreak down there is quickly contained and we can all meet up face to face. So today I am going to talk around digital health, and I've put the trip to Mars there, I guess, just to be a little bit provocative. And I'll talk a little bit about why in a moment. But before I start, I would like to acknowledge the traditional owners of the many lands upon which we're meeting today and pay my respects to the ancestors and descendants who continue the cultural and spiritual connections to the countries upon which we're meeting. Although you're hearing from me today, it would be negligent of me not to mention the many, many people whose work I will be talking about. And there's a list of them there on the screen, but there's an absolutely wonderful group of people who have contributed to this effort. And I just wanted to make sure that we acknowledge that so that their work is recognised. Many of you may recognise this person. It's Galileo. And he discovered, I guess, the way that the solar system and planets worked many, many centuries ago. What is interesting is how long it took for the knowledge in this field of astronomy to advance. So we had Copernicus join him, Kepler, and others. And despite the number of different people working in astronomy, the progress of the field was incredibly slow. It is interesting that may be because everybody working on astronomy was siloed. So you had the physicists working on it, you had the chemists working on it, you had the mathematicians working on it, and you had the theoretical physicists working on it. None of them really shared a common goal. None of them really shared their learnings. And there was nowhere for people from these different schools of thought to collaborate and talk about planets. That meant that the rate of discovery was incredibly low, shrouded in superstition and mistrust. And it's taken us many, many centuries to develop a new field called astronomy. Once we actually developed the field of astronomy, people from all of those disciplines came together and started to learn about planets. And they decided that we should undertake something called a one sky approach. And there's a great history of that written here. And what it shows that once astronomy was born, people from the different disciplines came together to work on a common goal, which is discovering planets. Transdisciplinary agencies such as the ESA and NASA were formed, which would have been unheard of before the birth of astronomy because they had engineers, physicists, chemists, mathematicians, all together in a single group working towards a single goal. And this is what happened. So you can see that digital health has many parallels to astronomy. We are a new discipline. We have people from all different schools of thought and faculties working independently, trying to solve the problem. And I guess what I'm proposing this morning is that we stop that approach, that we bring everybody who's interested in digital health together into a transdisciplinary group, united on a single goal, which is not discovering planets, but which is improving healthcare through digital health, create a shared language and create a shared vision. And what I'd like to be doing in 10 years' time is showing this graph, not with the number of planets that we discover, but with the number of lives saved through digital health. So I've got 4 goals really for the talk today. One is to talk you through where I've come from and why we're giving this talk. Secondly, to outline the problem. Thirdly, the solution. And lastly, to talk about learning healthcare systems. University of Queensland has declared digital health a strategic priority. And we have recently set up the University of Queensland Research Network, which I head. And that comprises 30 academics from 5 faculties, all coming together, I guess in a NASA-style approach, focused on digital health. And you'll notice that we have medicine, health and behavioural sciences, business, economics and law, humanities, social science, information technology, architecture and engineering. And if you'd asked me 10 years ago if I ever thought I would be in a team with a computer scientist and an anthropologist, I would have just laughed. But like the early astronomers found, working alone in this complex area is doomed to failure. And the formation of these new teams comprising multiple different schools of thought united against a common goal is going to be critical in advancing the science of digital health. You can see here exactly what the structure looks like. Multiple people across technical and humanities and health, all united towards improving care through digital health. And although there are multiple different people in this bubble, they're all working together. And how we've tried to frame that up is to actually have a common goal. So what are we actually all trying to do? And what we're trying to do is to create a smart healthcare system where all data entered during an episode of patient care is reused to improve the care of subsequent consumers. So that vision is underpinned by this aim, and many of you will recognise it. It's the quadruple aim of healthcare, which has been widely publicised and accepted globally. It's got 4 components: improving the quality of care, improving the efficiency of care, improving population health, and improving clinician experience or provider experience. And it's really important to always keep this quadruple aim in mind, because so often in digital health, you can get distracted by the latest tech, and that becomes your goal. Implementing the technology itself, delivering the project on time and on budget, instead of actually taking your thinking up to what are we actually trying to achieve, what is our aim, and it always needs to come back to that quadruple aim of healthcare. How do we get there? This strategy is for our group, but it really is an iterative strategy that covers the spectrum of where we're trying to get to in terms of improving the quadruple aim. So firstly, we have a group focused on digital foundations and digital workflows. How do you actually implement digital technologies successfully? Another group focused on retrieving the data and analytics from those digital workflows and creating new insights. And this includes descriptive analytics, predictive analytics, and hopefully in the future, prescriptive analytics. The third group looks at how do we take those digital workflows, the data and analytics insights, and create new and better models of care. You can see then that you actually end up with a virtuous circle as all of those horizons speak to each other. And underpinning it all is the enablers or the principles, which include things such as trust, governance, cultural readiness, and smoothing over digital disruption. I won't go through this in detail, but this is our operational plan that talks through the exact work packages and grants that we've got underway. So that gives you a little bit of context about how we're approaching this. I'll now talk you through the problem, the solution, and some of the actual practical steps which are underway to try to address it. So do we actually need to change healthcare? Or is the current structure and function that we have perfectly adequate? And I guess anybody that's looking at the current ambulance ramping, the state of residential aged care across our country, would have to agree that things need to change. So keeping on the same old probably isn't tenable, because we are going to see a 117% increase in health spending over the next decade. And healthcare expenditure for many nations is now reaching the trillions. We also need to change because of our people. We are starting to see a shortage of human resources. As the population ages, the proportion of the population which is young enough and fit enough to care for the elder generation is decreasing. And according to WHO, by 2035, we face a projected shortage of nearly 13 million healthcare providers globally, if we continue in the same model of care. And the third driver has to be demand. So we are continuing to demand more and more from our healthcare system. We have an aging population, we have changing societal behaviour, which is driving the increase in obesity and chronic disease. And this prevalence is expected to rise nearly 60% over the next few years. So we have a perfect storm for digital health. We have dollars, we have demand, and we have an issue with not enough people to provide the care. So those three things come together to, I think, propose digital health as a solution to provide cheaper models of care, to provide better models of care, and to allow all health practitioners to work at the top of their scope. But is digital health ready to do that? Is the technology actually ready to step up and meet those three drivers for change? And I'm going to show you a slide that many of you may be familiar with, Moore's Law. And this is a great slide that really shows that the number of technological innovations, and here we have chips, doubles every 2 years. So this is an incredible increase in the amount of new technology which is emerging every year. But I always follow this slide up with this one, because it doesn't matter if you've got a heap of new technology emerging every year, are people going to use it? And this slide shows that back in 1900, we were relatively slow to adopt innovations such as a telephone. And you'll see that very slow orange dotted line there as people worked out how to call each other. But we've become more and more adept at adopting new technologies. And you'll see that the line for adoption of mobile phones in 1990 is almost vertical. So humans are becoming more adaptable. Humans are becoming less fearful of adopting new technology in their day-to-day lives. So again, we've got a conjunction of not only an increasing number of technology emerging, but an increasing willingness and capability of humans to adopt them. So if you put those two ideas into context, this picture is from the 1950s, which is when the current models of healthcare were really established. And we've got to remember now that's nearly 70 years ago. And back at that time, healthcare was very different, and they actually used to sell cigarettes in the respiratory wards to help clean the lungs of people who were ill. In addition, other dubious practices at that time really were the establishment of episodic care, where you actually only had contact with the healthcare service when you were sick, come and see us every 3 months, fee for service, and the data that we recorded when we saw you in the outpatients in the 1950s and 60s was actually only for that episode of care. The quality improvement and monitoring of outcomes never happened. That was somebody else's job, and in fact they would send up whole departments to monitor quality. And research really wasn't part of healthcare. It was something different altogether and done in an ivory tower. And part of the reason for that is probably the patients that were being seen. So here's a patient from that time, a young fit gentleman with a broken leg. He's got a K-wire in there and some longitudinal traction. He would have come into hospital in 1951, had his traction, gone home, and perhaps not come back to the hospital again until he was in his 80s. That type of patient probably suited that 1950s model of care that I've described. However, these are the consumers that we're seeing now. Young people who are overweight. We have teenagers presenting with type 2 diabetes. We have young people in Australia in their 20s on dialysis from type 2 diabetes. This cohort is not going to come into hospital for a brief stay and then stay out of the system until they see us again in their 80s. They are going to require constant contact with us, constant support, and constant care so that they can enjoy lives long, varied, and healthy. So our 1950s model set up for this gentleman is unlikely to be suitable for this woman. So it's time that we moved on. We have a problem, we have technology that can potentially cure it, and we have a system which requires updating. So time to move on from those fabulous skirts. And I would argue that the way that we move on is that quality improvement and research become part of everyday healthcare. And we create what we call a learning healthcare system, where there is an infrastructure which supports complete learning cycles that encompass both the analysis of data to produce results and the use of those results to develop changes in clinical practices to allow continuous learning. And what that means is that the data that you put into your EMR is aggregated, insights are developed, the clinician sees those insights to drive better practice, create decision support, which is then re-engineered back into the system, and you get a constant virtual cycle of iterative improvement. And that's where research meets clinical practice, and digital health is that enabler. Traditional research has really, and quite rightly, focused on single issues: how to treat appendicitis, what is the best antibiotic for pneumonia. And it was really developed when the consumers we had were that thin, active young man that I showed you who had a single disease. The problem with traditional research now is that each consumer that you would put into a trial has 3 or 4 chronic diseases, and her needs and her comorbidities need to be considered holistically. This means that you actually need a digital platform to allow all of the characteristics of that consumer to be collected, so that when the researcher wants to examine a particular issue, there is a fulsome picture documented and recorded for that consumer, which is continuously updated. That leads us, I guess, to the practical problem of how does that happen? And this is the hierarchy of digital health infrastructure that we've been thinking about for some time. This shows the vast bottom of the pyramid as the general community who are free, living and well, that live happily in their homes. And the very top of that pyramid is people who are in intensive care, who are being managed in an EMR, whose every mill of urine and every breath is being recorded in an electronic system. What we're seeing is that at the very top of that pyramid, there's a very heavy investment in digital health infrastructure with deep EMRs, deep amounts of data, and up-to-date clinical decision support coming back to the consumer and the staff caring for them. At the very bottom of the pyramid, we have almost no information about our general population. We have no data to help them make decisions about wellness or how to stay out of the hospital. And the health system charged with caring for them has almost no information to prevent disease rather than treat it. So I guess quite rightly, with our 1950s thinking, we were focused at the top of the pyramid where we need the data and decision support to treat the illness. And we've assumed that the bottom of the pyramid doesn't need any data or decision support. However, what we're seeing now is that the bottom of the pyramid is going to need a lot of information, a lot of digital insights and decision support to stay away from the top of the pyramid. And in fact, over coming years, we may see the pyramid turn into a rectangle. So, how do we help? Let's go back to our research roots. So traditional research, we collected data to answer a single question. We centered our elements around a disease, and we did ask for comorbidities, but those were subject to things such as recall bias and were only sampled intermittently when the researcher spoke to the consumer. What we're seeing now is a shift away from that reductionist science, and clinicians are starting to embrace complexity science. We accept that the consumers have 3 or 4 illnesses, that there are multiple confounders, but that the data itself can be analysed in sophisticated ways to help us gain insights in how to prevent disease. So data in this model, complexity science, is fresh. It provides a complete picture of the consumer as much as we can, with all of the illnesses and social determinants of health that are required to prevent disease. And the data used for clinical care or normal living is reused to create these insights. And that does come with some data quality issues, as we'll discuss. The insights created by this type of complexity science are not only published, but are used to be incorporated back into the system to drive decision support to continuously improve. So that's that concept of a learning healthcare cycle. So the way that you approach such an issue is obviously different to the way we have set up research infrastructure for single disease questions. And this requires us to think about how do we prevent disease and not just treat it, if we really want to tackle the bottom of that pyramid and stop us becoming a rectangle. So for true complexity analysis, the sample size is everybody. For true analysis, in a complex phenotype world, you can provide real-time analysis and monitoring of outcomes rather than the intermittent analysis we do with the traditional RCT. Once you have those outcomes and they're being continuously collected, continuous monitoring and constant iterative change can occur to drive better outcomes. The trial design in complexity science is very different. Rather than deliberately excluding people with comorbidities, these comorbidities are embraced and the outcomes monitored. It allows us to undertake things such as pragmatic trial design, where we can, in the middle of a trial, decide that something is in fact an issue and stop. Or we can actually look at observational retrospective trials where, for example, there's multiple studies being published in the last 18 months where people have retrospectively examined routinely held healthcare to look at the difference in COVID outcomes between people who, for example, have had a particular drug versus those that haven't. There are downsides to this approach because the data extraction from a complex clinical system requires expertise and resources, whereas a clean traditional research collection usually requires a research nurse and a standalone database. There are also issues around consent because consumers can be individually consented for randomized controlled trials, where it is difficult to consent an entire population for an observational study. So again, just to recap, we've got a problem, we've got a solution, we've got a system that is no longer fit for purpose. We've got some ideas about how routinely collected data could help drive continuous improvement. How do you pull it all together? To do that, you really need a strategy that is iterative and builds upon the previous layer. This is complex and difficult to actually implement, and I'll share with you the approach we're taking. So the first aim is to embed digital data collection in as smooth and seamless a way as possible. So that's our horizon one. The second horizon is starting to take the data from those workflows and create insights. And the third horizon is to use those insights to create new models of care, new findings, and engineer them back into the digital workflows to continuously improve care. But this is complex. And I'm not afraid to say this is complex adaptive change. And the cost and complexity of this infrastructure is certainly daunting. But we are going to have to start making these observations and using deductive reasoning rather than relying on isolated RCTs to solve complex problems with consumers who have complex problems. The focus in a learning healthcare system is on implementation, observation, and continual improvement, rather than intermittent trials, intermittent publication, and the lag between that publication and translation into healthcare. The other complexity is this can't be done alone in the academic sector. Randomized control trials really can be done quite cleanly without necessarily having to partner with a healthcare service or healthcare provider or health prevention agencies. But I would argue that co-production of research, the sharing of research aims, goals, hypotheses, and methods needs to be shared between the academic sector and our healthcare and prevention colleagues. And this form of co-production is complex, however, is the only way we can pull together all of these threads across the academic sector and the healthcare sectors to provide the virtuous learning cycles to continuously improve. So I'm going to talk a little bit about a project which we are setting up here in Queensland called SMART, or Systematic Maturation of Analytics to Transform Healthcare. And really the idea is an attempt to start the learning healthcare system, some real infrastructure, understanding and capability in this space. When I talk about infrastructure, I'm not necessarily talking about hardware and software, although that's part of it. I'm also talking about human behaviour change. So the infrastructure required for the software, data extraction and everything else is critical, but that's relatively meaningless without the infrastructure to allow the insights gained to be translated into practice. And that requires support for executives and staff and clinicians as they learn how to change their behaviour and undertake the process of continuous iterative improvement. If you like, permission to learn. So here I have, I guess, simplified a learning healthcare system to talk about the various components and the way that we're going to address these in a systematic manner. And work has already commenced on all of these components, and I will show you some examples as we talk through the learning healthcare cycle. So the first is you need an EMR, and you need an EMR that not only delivers healthcare, electronic paper if you will, but an EMR that provides decision support. So instead of thinking as your EMR as a medical record, are you thinking about your EMR as a quality improvement tool? Because they're both two very different paradigms. And an EMR which is being used as electronic paper will not be able to participate in the learning healthcare system. An EMR which allows data extraction and the engineering of clinical decision support such as pop-ups, power plans and care sets based on newly emergent evidence can actually function as a quality improvement tool. So just keep that in mind as we go through the cycle, but this is not talking about your traditional electronic paper EMR. This is talking about an EMR which allows decision support to be engineered into the system. So that's critical. Secondly, you need an extraction engine, and anybody who has used an EMR will be very familiar with the issues around data extraction from the proprietary EMRs and the big systems which dominate the Australian landscape. So we cannot put in an EMR without thinking about how is that EMR going to contribute to a learning healthcare system, and have we got the resources to actually remove the data in a safe, well-governed and ethical manner. So I cannot overemphasize how important this step is. Usually when a hospital EMR goes in, the team who have the capability to extract the data are completely overwhelmed with operational reporting. So actually having the resources and the capability to extract data for research and quality improvement purposes is critical for a learning healthcare system. The third component down there is analytics platform. And I've put that as platform, but I don't just mean the tech, I mean the people as well. So there are reams and reams of data, petabytes of data. And what we actually need to resource up and have the capability for is analysis for that data. And we need two forms. One is traditional retrospective analysis. So our statisticians and our colleagues who are used to static retrospective work, but increasingly we are shifting to real-time analysis. Real-time descriptive analytics, real-time predictive analytics, and real-time prescriptive analytics. And this requires new forms of working, new forms of analysis, where we're using techniques such as artificial intelligence and machine learning to gather the data in real time and provide predictions. This type of work is new. It is not really been implemented anywhere globally at scale. So we, of course, will start slowly and humbly, but this type of infrastructure is something that we need to be thinking if we are truly going to move the healthcare system from break fix to predict prevent. Once you've analysed your data and you've come up with some new evidence for how we should be working, or a new process or a new treatment, those insights can span diagnosis or prognosis. You then need to be able to engineer that insight back into your EMR. And an example of that might be where you create some insights, put it in, and it goes straight back into your EMR. It takes about 3 weeks versus having a protocol that you publish that takes 7 years to be translated into practice. And the last component there is process change. So it's all very well to put something in your EMR, but is anybody going to act on it? So I'm going to give you some examples. So this is a deep EMR. This is a test patient from Queensland. And you can see that in the EMR, and this will be similar, I'm sure, to all of your EMRs, there's deep recording of each dose of insulin, exactly when it was delivered. And in other parts of the EMR is that person's weight, their renal function, their other diabetes drugs, whether they're eating or not, and what other medications they might be taking which would influence their blood sugars. This is an unprecedented amount of clinical data. We've never had the ability to record these items in real time. Perhaps we could have done a study about insulin and how it works 5 years ago, but we would have then missed the fact that this person also has inflammatory bowel disease, which might be also influencing their diabetes care. If we'd had a single isolated diabetes collection, we would be missing all of those other components to this person's phenotype, which might influence their response to treatment. We'll then talk about how we actually get the data out. So this is a schema for QUIET, so the Queensland Integrated Element Tracker. And this is a piece of software that the School of IT and Electrical Engineering at UQ has been working on in conjunction with eHealth Queensland. And what this actually does is it allows us to understand which elements we're going to collect. What do they mean? What is their definition? And where do they sit in the database? And this has been a real problem for us with our complex EMR because we have had people all over the place pulling out different elements and creating a relatively chaotic understanding of simple things such as arrival time in an emergency department. By actually having an agreed metadata tool and curating the SQLs that lead to the database, we can now build individual, governed and shareable data views for the data that we're extracting out of the EMR. For the first time, this allows us to share those elements and to have a common understanding and to allow the statewide relevant clinical bodies to govern their data view. So for example, in the insulin screenshot that I showed you, the statewide digital diabetes group governs that data view, agrees on the definitions for the elements, and is in charge of any insights or changes that might come out of the learnings. Then, how do you analyse it? So this is a proposal for our ability to actually take that data once we've extracted it with QUIET and analyse it. And again, credit to the University of Queensland School of IT, Electrical Engineering and eHealth Queensland. But the plan for this is to actually have an ability to have a research sandpit to create those phenotypes that we discussed so that they are accessible in a governed, safe and ethical manner to researchers. This would then hopefully obviate siloed disease-based data collections and allow researchers access to the true phenotypes of the consumers in all their glory of complexity. I'm happy to take questions about this at the end. And the last component is clinical decision support. So you have your data in the EMR entered, you extract it in a governed and clear way, it's analysed, and you come up with some insights. What do you do with those insights? So firstly, you need to publish them and they need to be peer reviewed. But secondly, you can engineer them back into the system. And this is just showing you an example of some decision support engineered into our EMR, where you can take some evidence base from the data that we've entered, extracted, and analysed to give clinical decision support, which we know is locally relevant and helpful. The cycle then continues because the answers to the clinical decision support are recorded. So if the person accepts the decision support, we know. If they decline the decision support, we know. If they change their order in response to the decision support, we know. So not only can we create the decision support, but there is another secondary loop where we examine the efficacy of the decision support itself and its effect on outcomes. Not only is there individualised decision support, one-on-one for clinicians and care providers at the bedside, there's also decision support available at a system level. And what I'm showing you here is the inpatient diabetes dashboard. And what this does is, again, building on the layers I've showed you this morning, allow the aggregation in real time of blood sugar levels and insulin doses across hospitals. It allows that data to be filtered, and you'll see at the top there, we can actually filter in real time for patients who've missed their insulin, for patients who have had hypoglycemia in the last 24 hours, or patients who've had a poor glycemic day. And we have a definition for what that is. It's essentially sugars over 14. That allows us in real time, at a glance, to understand which consumers living with diabetes in our hospital are experiencing adverse outcomes in real time and intervene. At the moment, this is simply a descriptive dashboard. It's simply showing us what is happening. But you can imagine that we're working feverishly to shift from description to prediction. So what if we could actually predict that that person on Ward 7 is going to have a hypoglycemic event instead of simply seeing it? And what should we do to intervene to stop that event? So I think we're still in our infancy. We're still only at descriptive, but to have real-time descriptive analytics coming out of the EMR is, I believe, one of the first components for a learning healthcare system. They are currently only descriptive, but we have work underway to shift that from descriptive to predictive. And the last one is process change. And if you thought it was complex talking through all the technology, wait till we get to this one. So according to a great paper by Jeffrey Braithwaite, this is how people in a hospital get told what to do. And apologies for concentrating on the hospital component of this. There is, of course, another whole paradigm in terms of residential aged care, primary care and community. But I will talk to this example in a hospital. So this is how a hospital hierarchy works when you write it down on paper. So theoretically, if you're going to get process change in a hospital, you go to the person at the top, say, well, the EMR says that we have to do this, this, and this, and our analytics tell us that this is the best way to work. And that instruction would cascade nicely down through the hospital. In reality, this is what happens. And it's chaotic and it's difficult, and nobody actually does what the person above them tells them to do. And you will see there are some people in there who are hyper-connected, who all the arrows go to. They may not be high on the traditional hierarchy, but in terms of influencing behaviour, those people are leaders. And in a learning healthcare system, this cannot be a top-down change. It needs to be a bottom-up change, if you will, because the decision supports are not going to the CE or the executive director. The decision supports we're building are going straight to the clinicians. So we've actually landed ourselves with a complex adaptive change that probably isn't going to be solved by traditional hospital or healthcare hierarchies. And that is because what we're describing is not a technical issue that an IT person can fix. It's a people issue that only people can fix. So we really need to start embracing complexity science. I was trained in reductionist science, where we would isolate every possible confounder until we had a pure system, make a simple change, and then make a conclusion. Real life and digital health is unable to be isolated in such a reductionist manner. And so we have to embrace complexity science if we are to advance our field. And that's because there is this difference between complicated phenomena, such as the, lab-based work I did for my PhD, which was reductionist science, and complex phenomena. So when you're talking about complex science, you can use linear logic, you have fixed discrete elements and predictable boundaries. So that's traditional science. When you're talking about complex phenomena, complex adaptive change, which we see in digital health, it's an open system. Non-linear thinking is critical, as I showed you with that governance diagram, people influencing each other with behaviour change. It's subject to external influences that we can't even imagine, such as political issues, disasters, clinical change, a host of things that you simply cannot control for. And organisational dynamics shift and variables change all of the time. So instead of approaching the process change in a learning healthcare system with technical change, such as they might do at Toyota, where here are some evidence I want you to change, and that traditional hierarchy model, we need to approach this with adaptive change. And adaptive change really looks at how organisations work and how we empower those at the coalface to make decisions and change their behaviour in a governed and data-driven way. This adaptive change is difficult because it challenges previous assumptions and long-held beliefs. It requires new knowledges, new skills, and people to listen. So I'm not at all suggesting that adaptive change is easy, but by giving analytics and data to frontline clinicians, that's what we're asking them to do. And so many of you may be familiar with this curve, and we will see it. So this is grieving during change in healthcare. And when you have clinicians who perhaps have been doing exactly the same thing for a very long time, when confronted with data that perhaps challenges their perceptions, we see an interesting reaction where you often see people paralyzed initially. They then get angry, say that the data is false. Then we go through a bit of bargaining, and then you get some quite heavy depression. But usually, if people are clinicians who really do want to make a difference, they start to change, and their behaviour starts to change, and they start to adapt. And I really put this up, I guess, just to make sure that we understand and respect the changes that giving data to clinicians will produce in order for everybody to learn. So traditionally, learning was something we did at university, and then perhaps we read research articles and went to seminars. Now we're challenging healthcare and making it transparent, and asking our healthcare providers and our consumers to constantly potentially be exposed to outcomes, to understand them, and to empower them to act. So I don't think this is necessarily going to be easy, but having lots of different teams across the disciplines involved, I'm hoping will allow us to navigate this change in mind shift with some elegance, respect, and grace. So I'm going to stop soon, but I just wanted to bring us back to why are we doing this? And it's not because I love technology or because I think digital things are cool. It's to satisfy the quadruple aim of healthcare in the face of ever-shrinking resources, to improve the quality of care, the efficiency of care, the experience of our teams, and to improve population health. And I'm actually going to play a little video now from the NHS, which I think gives a really nice summary of how we might do that.
We all want a sustainable, high-quality health service in the UK that continues to improve year on year. A health service that can build on and learn from the millions of people who work in and use it every day. A health service that can adapt and thrive in the dynamic, fast-changing world we live in. So at the Health Foundation, we're excited by the potential impact a learning healthcare system could have for all of us. Imagine a health service that could understand and make sense of everyone's knowledge and experience about what works best, and then share the lessons quickly to allow others to build on what's being learned. Everyone in the system could expect to benefit. For example, patients and service users would be at the centre of their own care, connected with and supported by networks of people with similar conditions, and their care would be more personalised, coordinated and effective. People working at the front line would be able to share their knowledge for the benefit of all and play a more active role in helping to improve services, while working in a smoother running, more joined up system. And policymakers and system leaders would have quicker access to meaningful facts and figures about changes to care quality, so they would gain a better understanding of where to invest funding, what's really working, and what should be prioritised to make care better. Every person in a learning healthcare system might contribute their thoughts, knowledge and data in some way, and this collective information could be used to inform the next person's care, the next research insight and the ongoing development of the health service. With everyone's energy focused in the same direction, one change might lead to the next, more efficiently, more quickly, time after time, leading to improved care for all. So, what could be done to make this happen? Let's make the most of the latest digital technology as we gather, interpret and share information. Let's connect with each other, build networks and partnerships to learn from one another. Let's make sure there are enough people in the NHS skilled with the modern improvement techniques needed to improve the quality of healthcare. And finally, let's do everything possible within the system itself to make it easier to make change happen. Let's do these things, because a learning healthcare system has the potential to continually build on the collective strengths of the NHS, for the benefit of all those who use it.
So I'm going to stop. I'll finish with a picture of Mars taken by the Perseverance rover over the last week. And I guess what I like about this is watching the maturation of the space industry and thinking about it, and the way that the transdisciplinary teams came together with a common goal over the last 100 or so years to really understand how to all work together and to get human endeavour to Mars, makes me hopeful that the transdisciplinary teams who are currently all working in digital health might be able to come together with a similar vision, and that in 100 years' time, our healthcare services might be smarter, more intelligent, and better able to care for those who need them.
Oh, thank you, Claire, for that brilliant presentation. Very thought-provoking and inspiring. So we have several questions in the chat that we'll turn to. I'll start with Daniel. You want to just ask your question, Daniel?
Okay. Yeah. So my question is, how do we reconcile, this idea of the learning healthcare system, which has been around for some time, with the level of documentation that needs, and the recognition that a lot of these systems are generating overburdened clinicians and burned out clinicians in the long run?
Yeah, and there's no easy answer to that. So we are certainly seeing a change. I think and we know the evidence from the literature tells us that the biggest burnout is in systems that depend upon notes for financial reimbursement. So particularly in the USA, where the notes are a critical component of your reimbursement, we see things such as note bloat, where unless you actually document what you have seen in your entry in the EMR, you will not be financially reimbursed. Now, we have a very different situation, thank goodness, here in Australia, where our financial reimbursement and our financial models are not dependent upon clinicians writing things in the chart. So we are seeing a lesser degree of note bloat here, but I think it is something that we need to be mindful of. I also think as technology improves, that burden will lessen. So we start to see dictation, we start to see predictive notes. So I think we are at a generational juncture right now where it is an issue, particularly in those areas of the world where reimbursement is dependent upon notation. But I'm confident over the next 5 years that burden will decrease as our digital natives come in, and as we start to understand how to better caption notes without necessarily having long typing efforts. So I think we'll get there, Daniel.
Thank you.
Thanks. Zarina, would you like to unmute and ask your question?
Yeah, happy to. So I was actually wondering about the collected data within your learning healthcare system. So does the collected data include input from all clinicians, so medicine, nursing, allied health, particularly on things such as social determinants of health, to help characterize individual consumer or patient? Or is this data actually derived only from biochemical measurements and then linked back to the consumer without taking determinants into consideration?
So, Zarina, just to paraphrase, because you're breaking up a little there, you're really asking about, are social determinants of health part of the learning healthcare system?
Yes.
They absolutely are.
Fantastic.
Because if you remember the pyramid that I showed, the social determinants of health are one of the real reasons why you move up to the pointy end, right?
Yeah.
So if we're going to shift from if we're going to shift from break fix to predict prevent, we really need to understand what are those social determinants of health and provide the same level of digital infrastructure, understanding and insights to those social determinants to help prevent people actually shifting up to ICU. So it's critical to me that we don't focus on the pointy end of the pyramid, the people in ICU, but that we actually look at how do we actually stop our population progressing along a disease trajectory. And so understanding what it is that promotes disease trajectories and looking at how we can actually undertake prevention in that bottom of the pyramid is going to be critical. So Zarina, you're right to call it out. The problem we've got is that all of the investment in terms of digital infrastructure currently occurs at the pointy end.
Yeah, exactly. Thanks very much, Claire.
Yeah.
So Claire, I think we all on this call see the potential of academics and health services working together. You're someone who straddles both. What are some of the challenges that you've seen and had to overcome?
Doing everything badly. Look, I think it is difficult because both are critical. And so I'm not sure that academic health as a standalone is necessarily sustainable anymore either. We're seeing the MRFF and NHMRC shift towards wanting to see firstly partnership and secondly, quite rightly, evidence of translation into practice. Now, if you are working without contact with a health provider, your ability to satisfy those new research outcomes criteria is increasingly embarrassed. So I think there are drivers now. As an academic, we have to modify the way we work and fit in with some of the healthcare demands, which is sometimes hard. And from a health sector, they are strained and just struggling to even deliver healthcare. So to free up any mind space at all to engage with the academic sector is a challenge. So again, we've got two different institutional logics, right? The academic sector who need to publish paper and create new knowledge. We have the healthcare sector who need to deliver healthcare. The challenge is aligning those two institutional logics and bringing them together so that the publication and creation of new knowledge is not an end in itself, but it lines up with the health services institutional logic, which is to deliver better healthcare. And the thing that unites them both is the quadruple aim. So having a shared vision and a shared aim does smooth down some of those differing institutional logics and allows the coming together of those really important resources. So it is a new way of thinking. It is a new way of working. But I think we're seeing it start to happen. And when you look at the States, for example, Wendy, as you know, those big healthcare, academic healthcare systems are absolutely intertwined, academic sector and health sector. So we need to start picking that model up in Australia and starting to make it happen, bring it to life.
Thanks. Brian Chapman has a question.
Oh, I didn't know I had to.
Yep.
But so, you know, Chuck Friedman, who you quoted earlier, walked away from the ONC in the US, which directed meaningful use, saying top down doesn't work.
Agreed.
So you're, any sort of bottom up revolution is going to introduce some element of chaos and mistakes along the way. So how well suited is healthcare for tolerating that, and what sort of mental attitude changes might be needed to facilitate that?
That's such a good question. And it's interesting to me that we look at digital health in isolation, Brian. So we see mistakes and learning with any new component of medicine. So when we introduce a new drug, look at the COVID vaccination, we're seeing mistakes, right? And adverse outcomes. We're seeing thrombosis, we're seeing reactions. That doesn't stop us. When we introduce new surgeries, we do see mistakes that happen, unfortunately, and side effects. Now, I don't think digital health is as dangerous as either of those two, but it is pioneering and it is a new way to do medicine. So I think we have to accept that we learn as we go, that we won't get it perfect. The same way with any new chemotherapy agent that we introduce, we know that there are side effects that come along with that chemotherapy, but overall, we know that it prolongs life and it improves quality of life. So I see digital health as just the same as a chemotherapeutic agent or a new operation or a new drug. What's important is that net benefit is there. We can't expect perfection from chemotherapy. I don't expect perfection from insulin, but I do expect that the net benefits outweigh any downsides. So I think we frame it up as we do anything in medicine. Clinical medicine is constant risk management. Whenever I prescribe insulin, I'm managing risk. But I know overall that it is beneficial for the patient. So it involves a discussion with the stakeholders and an understanding of mutual risk appetite. But we can't expect perfection from digital health because we don't have it in any other component of medicine.
Great point. And then we need ways to be measuring it proactively so that we're catching those errors too, it seems like.
Correct. So if you're actually monitoring your outcomes in real time, you have the ability to intervene quickly and correct. Whereas if we took a traditional research mindset, we might not look at the outcomes for 2 to 3 years.
Right. Excellent. Douglas Perez.
Oh, hi, Claire. Thank you very much for a very interesting talk. I really, really enjoyed it. My question has to do with data science. Do you think digital health as a community has the data science maturity and the capabilities necessary to go really from descriptive to predictive, considering the risks of biased predictions, for instance? And where do you see the roadmap going from descriptive to predictive?
So Doug, the answer is no, not yet. So most of our data scientists are trained in static retrospective data sets. And I had a really interesting conversation with someone that said, well, real-time data is not data science. Which is obviously not true. So how do we think about that? How do we shift ourselves from traditional retrospective analyses to real-time? And there's work underway all around the world, as you know. The challenge is that the work is not really yet been implemented. It's still in the lab. So I think, and I'm hoping that Australia can be a global leader in this space, because the isolated retrospective analyses are helpful for publications, which could potentially set new targets or new ideas in our learning healthcare system, but they're not going to drive the continuous improvement, which we clearly need. So how do we articulate that across the data science community? How do we start to focus that thinking? And I think one of the things that has held us back is all that the data scientists have had access to is retrospective data sets. So what do we expect, right? Everything looks like a nail when you're a hammer. So let's give them some access to real-time data. Let's start to expose people, build those new teams, build the NASA, right? Have those different teams working together in a NASA-like way, rather than having the engineers off working separately to the scientists. Have them all together with that access so that everything doesn't look like a nail.
Fantastic, thank you.
Joanna, would you like to ask your question?
Yeah, sure. So I think the presentation was really great, and I really like the vision that's really big and good for healthcare. But I just see like missing data is really a big problem with completeness and accuracy. And with a claims-based system, we do have better recording of what has been claimed. But there's also maybe like inaccurate diagnosis, because some things you need to put under certain diagnosis to be claimed. Yeah, so I guess like the question is, has this been measured in this, what UQ has implemented in Queensland?
Yeah, so we know that mistakes in data happen all the time, Joanna, and there's multiple papers talking about the issues with real-time data and how you analyse it. So happy to share some of the approaches that we've been using. And your first one was around inaccuracies. And one of the best ways to increase your data quality is to start presenting it back to the people who enter it. So if you never see the outcomes from your patients with diabetes, you don't really care what goes into the system, right? But what we found is that by starting to play back the analytics to the people who are actually responsible for entering the data, you see a dramatic increase in your data quality. So that's the first one. And we really noticed that around nursing assessments. So we created some analytics that in real time showed nursing staff the completeness and accuracy of their pressure injuries risk assessment scores in real time. And I promise you that we suddenly saw a rapid increase in the adoption of those forms. So that's my first one. The second approach is that sometimes you just can't find a way to increase your data entry or your data accuracy. And that's where we're starting to do imputation. So this is our MRFF project, Empower, that I briefly touched on during the presentation, where we know that the SNOMED CT coding of things such as dialysis is poor and inaccurate. So rather than simply going to that field and going, oh, missing data, it's not there or it's wrong, we impute. So we say, okay, their creatinine is over 400, their EGFR is less than 30, they attend the renal outpatients and they have 16 dialysis sessions every 4 months. I think they're on dialysis. So that way you actually create a phenotype that is imputed from various elements that we know have high quality, and we impute a phenotype. So you don't always have to rely upon individual data fields to impute a phenotype. And that's what our MRFF work is really about, because we understand there are issues around some of that data entry which are insoluble. However, by developing phenotypes, we can impute and bypass some of that. I think that honestly is the future, that we're never ever going to get doctors and nurses and allied health practitioners to tick every box, but we can be smart and we can actually start to use AI techniques to impute phenotypes. Sorry, I'm getting a bit meta here, but we can to create those phenotypes. So I think and that's why we need these transdisciplinary teams. If you're a data scientist in the lab, you can never do that, right? So how do we actually create transdisciplinary teams which allow imputation to bypass some of the data issues?
Oh, thank you so much, Claire, and thanks for the excellent questions. We will send a follow-up email with a link to the video so that everybody that would like to share it or watch it later is able to. And thanks everyone for attending.
Thanks for having me.
All right, talk to you later, bye.